versus not painful?
So if it's painful, what I usually think is that it's not that it's any different, it's that it's a lot more sore, because usually when you load the joint, it takes some of the sensitivity away. It's kind of how I judge how flared up they are. So when you put them in quadruped rocking, and if they can't rock back anymore and they could do it previously, then something's a lot more sore than it previously was. So it's just more of a sensitivity test as opposed to, is there anything different going on? Because most all the time you put people in quadruped rocking within 4 or 5 days, it feels great and it's their favorite exercise. So for that to become painful all of a sudden, then I'm like, you've probably done something that's really irritated the joint.
Joe, with your higher level patients who wanted to get back to running and what do you like to do to get back that function?
I've been toying with this a little bit. I mean, what I've been having some patients do earlier on is a little bit of just TA with marching. But what I've started doing is just very basic reverse lunge. So going down like if they were standing on a step here, and it was this position, little to no weight on their front foot, and then they go down, and then they have to bring themselves out of it very slowly. You can either do that with a TRX or some type of assisted activity, but that's the one that I've been using the most. Sometimes I do have them do sprint mechanics, where they stand on a wall and they try to pull in their core, and they're basically firing their leg through a running type motion. And I do that, and we start out very slowly, but then we start to pick up the speed, and they try to do that for like a minute, but usually they don't make it a minute in the first time, so I try to use that a little bit more. We let them, too, if they can get in the pool and kick. I think that's a good way to do it, but that's only going to get so far, because most people, unless they're a triathlete, don't like to get in the pool and kick that much.
The only thing that you don't want to do this stuff too early.
Right.
Yeah, so this is, you know, I'm getting kind of scared here. I'm nervous, Joe. Nervous.
So earlier on for cardio, I know I've read treadmill is not a great idea. What do you think of elliptical?
I let most of the patients get back on the elliptical in about 8 to 10 weeks, because they're usually not having any issues. They're farther enough out, and we're doing some pretty high level stuff. But that's usually kind of where I hold them to, is the 8 to 10 week mark. Because once I get past the 12-week mark, and Dr. White tells his patients this, you're pretty safe to have a flare after that. But that first 12 weeks, if you can avoid any type of flare, so I'm more apprehensive and letting them try that stuff. And if they've had any type of flare incident, then I probably am going to wait a little bit longer.
Yeah, and I mean, for me, Sean and I we're preaching the whole time. It sounds really stupid and perseverative in that we just said everything is slow. It's a 6-month race. And so, for me, I actually would probably push the elliptical out a little bit more, 3 or 4 months range, because I do see some flares in 2 to 4 months that can be pretty severe. Now, everybody's different in what they come up with, and that's why I'm kind of against the bubble sheet of kind of saying when it's safe, because you'll know if somebody is walking terribly and they've got this horrible weak gait, they start going into Trendelenburg. That's not somebody just because they're at 4 months you can put on an elliptical. And so, in general, for me, I typically say start picking up the resistance around the 3-month mark. If you want to start kicking a little bit in the pool, I think what Joe's talking about is a lot of short arc stuff, really simple stuff. But for swimming with kicking, I typically wait on that for about 4 or 5 months, because everybody's different. I just don't want to initiate a flare. And then for me, a running progression usually starts around 5 months, and that's jog walking about a mile. And so these are sort of the ultra conservative side I have, because to me, I don't want to sound insensitive, but I don't like it when patients don't do well. It really bothers me. We can have 40 patients that do well and 1 that doesn't, and that's the one I'm going to take home for weeks until I find out they're doing better. And so I'd rather people err on the side of going slow. To me, I really hate it when people come in at 2 months. Like I don't want to brag about the ones who come in at 2 months that are doing super well, and that's awesome. I'm impressed with where they're able to go with the joint motion alone, because that's all I'm really testing. When they come into the clinic, I'm testing the joint motion. The muscle strength and everything else, I have to defer to you guys. But for me, I just don't want them to kind of ramp up and fall down. Because the worst patient is the patient that does well, really, really happy with you, and then flares, and then comes in really unhappy. because a lot of times I'm hamstrung and how to get them back. And a lot of times they don't want to regress and go back on crutches and things like that. I'd rather people take their time and stay on crutches for 8 weeks. I love that. I love seeing you on crutches. I love it. I love
For the swimming.
But that's what I kind of want. I want everybody to take their time because this is a marathon. If you go slow, it makes me very happy.
But as far as the cardio stuff, I'll let them, like with a pool buoy. I mean, I don't let them kick. And I always tell any patient that comes and see me and then is leaving, if they're coming from out of town, is the one thing you learn from leaving me is that you're never to have a pinch in the joint with any exercise, ever. So if you're 3 sets of 15 of squats or whatever, and on the 3rd set of the 10th one you get a pinch, you stop that exercise today. We may can come back or we need to modify your form. But they don't ever have any pain that reproduces that symptom actively ever. So that's one thing that I really preach when they come into me, and I was like, you may not follow this dot sheet or do exactly what I say, and that's fine, but this is the one thing that we can't negotiate on. You can't have this, because if you have it once and you get that therapist, oh, I'll just push through it, then that's when the people get into trouble, is they went through that and they shouldn't have. And then as far as when I do have them get in the pool and kick, I usually make them use a board, and they have to do like just super slow, like very exaggerated kick. I don't let them kick fast. I said it may take you 10 minutes to reach the other end of the pool, but it's just some slow motion just to get a little bit of activity. What you could also do is, I have it do it in some patients that I'm less concerned with, is just when you add the walking is to do some marching as well, just really slow, so the buoyancy kind of brings their leg up. And then again, can't have any pinching, and if you do, you stop that exercise immediately.
And I think, with Dawn here, she came up with a really good thing that helped. You see, what she told me that I thought was really helpful was she said, if I have some pain with an exercise, or it feels like a muscle soreness, but Dawn, why didn't you tell me what she said? I don't want to mess with it. I'm sorry. You okay with that? And if it lasts into the night or the next day, we're a little bit concerned and we back off that exercise for a week or 2. That's a really nice, helpful, concrete rule that just helps you stay out of trouble, and I thought that was perfect. So the nice thing about all this is we have a lot of physical therapists now that have gone through it. Those are sort of our super resources. And Joe's definitely one of them, Don's one of them. So Van, it's good to just kind of talk to your colleagues, and that's what's so wonderful about all you guys coming tonight. This is wonderful for you to know each other and talk to each other, because this is hard. This is not like rehabbing an ACL or a rotator cuff, and I think collaboration is the key.
A lot of things can go wrong.
Yeah, a lot of things can go wrong, and it's not always easy to figure out what it is. That's for sure. Great. Oh, thank you. And then special thanks to Libby and Angie, for videotaping this. We'll add this on the web, so if your colleagues want to take a look at it or you want to take a look at it again, we'll figure out the best format to do it. But I really appreciate everybody coming. I really appreciate Joe putting this together. That was wonderful. This is great. So thanks again. We'll try and do it again next year.
Thanks.
Thanks.